Hi everyone, welcome to this lecture. This presentation will cover the bladder injury from a urologic academic standpoint, and I am your instructor Dr. Junaid Bajwa. Let's start with our lecture. Although bladder injuries are not common, they have high clinical relevance because of their association with significant trauma. They account for around 1.6% of blunt abdominal trauma. Most are extraperitoneal, followed by intraperitoneal and a small fraction that are combined. Also, a large proportion of bladder injuries occur in the setting of pelvic fractures, underlining the need to suspect bladder trauma when pelvic fractures are present. Understanding the bladder anatomy is critical. The bladder is located deep in the pelvis, but its position changes markedly with filling. When distended, the dome can rise and become more exposed. The dome is covered by peritoneum, making it particularly susceptible to intraperitoneal rupture under high pressure. The bladder neck, in contrast, is quite fixed by pelvic ligaments and fascia, which has implications for injury mechanisms and repair. Finally, its close relationship to pelvic bones and surrounding structures means that pelvic fractures frequently damage the bladder. As you can clearly see the parts of the bladder in this picture, you can see the uh, trigone of the bladder, you can see the detrusor smooth muscle of the bladder, you can see the bladder neck, you can see the both ureteric orifice, right and left, you can see the internal sphincter located at the bladder neck, and dome is not highlighted in this picture, but it is present on the peritoneal fold, on the side of the peritoneal fold. Mechanisms of the bladder injury. Bladder injury can happen through several mechanisms. Blunt trauma, usually from high velocity accidents or pelvic fractures. Penetrating trauma, such as stab wounds or gunshot wounds. And iatrogenic injury, particularly occurs during pelvic or urological surgery. A distended bladder is particularly vulnerable to rupture during blunt trauma. Surgical or iatrogenic causes, such as during transurethral resections of the prostate or gynecological surgeries, can also predispose to bladder injury. This picture is showing the orientation of traumatic bladder injuries. Blunt trauma due to genitourinary tract surgeries, penetrating injuries, and iatrogenic injuries. Classification of the bladder injury. Classifying bladder injuries helps us to guide the management. Anatomically, injuries are classified as intraperitoneal, extraperitoneal, or combined. Clinically, we also assess severity. For example, contusions like partial thickness versus lacerations, with further grading depending on depth, length, and whether the neck or trigone is involved. This classification aligns with widely used American Association for Surgery of Trauma classification system. This picture is depicting the intraperitoneal injury and extraperitoneal injury. As you can see, intraperitoneal injury is occurring towards the dome along the peritoneal fold, and extraperitoneal injury is occurring towards the base of the bladder. The pathophysiology differs for intraperitoneal versus extraperitoneal injuries. Extraperitoneal injuries often occur in the bladder base or anterior lateral wall, especially when pelvic fractures produces bone fragments that pierces the bladder. In contrast, intraperitoneal ruptures most often involve the dome, where the bladder is covered by peritoneum and less supported. These intraperitoneal ruptures frequently follow a sharp increase in intravesical pressure. For example, if the bladder is full and then suddenly compressed, when urine leaks into the peritoneal cavity, the peritoneum can absorb it, leading to metabolic derangements like azotemia or electrolyte imbalance. Clinically, patients often present with gross hematuria. This is one of the most consistent signs. There may also be suprapubic or lower abdominal pain, and in intraperitoneal rupture, signs of peritonitis can appear. Sometimes there is difficulty in voiding or oliguria, especially if the bladder is ruptured or the injury disrupts normal filling or emptying. Because bladder injuries often come with other trauma, for example, pelvic fractures, it's important to look for accompanying signs like shock or bony instability. To diagnose bladder injury, labs and imaging are vital. Urine analysis typically reveals hematuria. In intraperitoneal rupture, absorption of urine may raise serum blood urea nitrogen and creatinine, so metabolic labs are also useful. Imaging wise, retrograde cystography remains the gold standard. In trauma patients, especially, CT cystography is often preferred because it can be done alongside other imaging and can identify other associated injuries. While ultrasound like fast scan can detect free fluid, but it is not specific for urine versus blood. Imaging findings on imaging, extraperitoneal bladder rupture classically shows contrast leaking into the perivesical space and remaining confined around the bladder base. In intraperitoneal ruptures, contrast often outlines the loops of bowel and fills peritoneal recesses. In plain film cystography, taking a drainage film after contrast installation helps to detect leaks that may not be obvious during the filling phase. Management depends heavily on the lesion's location. Intraperitoneal ruptures almost always require surgical repair as per the AUA guidelines. Extraperitoneal ruptures, if uncomplicated, are often treated non-operatively with continuous bladder drainage via Foley catheter. However, there are important exceptions. For instance, if bone fragments have pierced into the bladder, or if there is injury to the bladder neck, or additional vaginal or rectal injuries, or if there is pelvic hardware insertion, then surgical repair becomes necessary. After repair, urethral catheterization is generally sufficient. Suprapubic tubes are not always needed and may not confer additional benefit. When repair is indicated, the typical surgical route is a lower midline laparotomy. In some stable cases, laparoscopic repair may be considered. Surgeons should debride any devitalized tissue. The bladder should be closed in layers, first the mucosa, then the muscular layer, and finally the serosa or peritoneum. It is also critical during surgery to inspect the ureteral orifices and the bladder neck to make sure that they are intact. After repair, catheter drainage is maintained to allow the healing. This picture is showing the closure of the bladder. One layer closure is also performed and two layer closure is also performed. Potential complications after bladder injury and repair include infections, fistulas depending on associated injuries, and long term bladder dysfunction. For follow up, cystography is often recommended, especially in complex cases to confirm healing. Also, newer evidence suggests that prolonged catheterization can increase morbidity. For instance, a study found that patients whose Foley catheter remained for more than 14 days had more complications. Therefore, carefully tailoring catheter duration to the individual case is very important. Overall, when bladder trauma is recognized early, imaged properly, and managed according to best practices, patients do very well, often recovering normal bladder function. However, prognosis may be worse in more complex injuries, such as those involving the bladder neck or trigone, and or when there are significant associated injuries or delayed repair. To summarize, clinicians need to suspect bladder injury in the right trauma context, particularly when pelvic fractures are involved. Key signs include hematuria, voiding difficulties, and lower abdominal pain. Imaging via cystography is essential. Management depends on whether the rupture is intraperitoneal or extraperitoneal. Finally, good follow up and catheter care are vital to ensure proper healing and to reduce complications. That's it from today's lecture. Hope to see you in upcoming lectures. Take care. Goodbye till that time.